Good morning, everybody. I think we will make a start. So I'm glad to say a not very warm welcome. It's a wonderful room to be in today, isn't it? Great aircon. So thank you to whoever booked this place. And welcome to colleagues and friends who've joined us in the public gallery today. Very good to have you with us. We don't actually have any apologies today, so we are a full house. However, I would like to note with great sadness that today is the last board meeting for both Martin and Sue, both of whom have reached the end of their terms, as did Sean, who is also therefore no longer with us. But really, thank you so much to both of you for everything you've done, and also to Sean in his absence. We will really miss you. And I know that we'll have another occasion when we will all be together, just not in public. And we will be meeting to say fond farewells in due course. But just wanted to acknowledge the huge contribution that you've made and to thank you for everything you've done and wish you well for whatever you do next. Okay. I think we will move on then to Roger's story. Roger, delighted to have you with us, and Emily with you. And we're very much looking forward to hearing from you and learning from your experience. So over to you.
Okay. Thank you very much, and thank you to Emily for arranging for me to be here today. My name is Roger Broadbent. I'm a 69-year-old father of three, a retiree. I've been retired now for 3 years. Prior to retirement, I was a self-employed health and safety consultant, fire risk assessor. Prior to that, I was 36 years with a global company providing fire and security services across buildings that you guys will be fairly familiar with, I think. I live in Longwell Green in Bristol. My youngest daughter is still at home with us. My two elder children had the common sense approach and left a few years ago. Married to Sandra, lived in Longwell Green now probably for about 30 years. And I have a couple of hobbies, mainly centered around DIY and repairing things that go wrong. And I have a 1961 Morris 1000 that I tinker with from time to time. They do need a bit of tinkering, as do old people like myself. I'm going to go through quite a few dates, really just because I can then remember where I am in the scheme of things, and just to probably impress upon you how quickly I've been seen when necessary, and where delays have occurred also when necessary. So my story begins on the 3rd of July, 2025, when I was sat on the decking of our static caravan down in East Devon, near the Donkey Sanctuary. And for some reason, still unknown to me, I went like that and thought, ooh, there's a lump in the side of my neck. And I'm the sort of person that knows that lumps in necks are not a good sign. So that was the 3rd of July. That was a Thursday. I took myself to my GP, Leslie Haynes, at Close Farm Surgery on the Monday, just a few days later. Leslie looked into my throat and said, "Does your throat hurt?" And I said, "No." She said, "Have you lost your voice?" And I said, "No." She said, "Can you swallow successfully?" And I said, "Yes." And she said, "The back of your throat is badly inflamed, ulcerated, very, very yellow. And I think you should be referred on a fast track 2-week referral for further exploration of what that may be." So on the 21st of July, I went to ENT at St Michael's Hospital, saw a Dr. Ilko Genkov there, who surprised me with a nasal endoscopy. He gave me some tissues. I didn't know what that was for, but I found out soon enough that that was for leaking eye syndrome. And to have an illuminated camera into the nose and down the throat came to me at that time, as you can imagine, as a bit of a surprise and maybe a bit of a shock. Dr. Genkov was a really straightforward sort of gentleman. I said to him, "Can you tell what the problem is?" And he said, "Yes." I said, "Would you be prepared to tell me?" And he said, "It's some form of cancer." And I said, "Is it treatable and is it curable?" And he said yes to both. And I was quite delighted to hear that information, having obviously been given fairly recent bad news. Fast forward then to August the 8th, I had a CT scan at the BRI A217. I had a radiology scan under ultrasound with a fine needle guided aspiration of what I now know is the lymph node in the side of the neck, this to ascertain what was going on there. That was taking place at the Bristol Dental Hospital. And on the 12th of August, also at the Bristol Dental Hospital, I met with a team, James Artingshaw, a registrar, Georgina Caswell. I've spoken to Georgina several times since. She's a consultant. Hiro Ishii, who is an ENT specialist consultant surgeon. Rob Buller from Macmillan, and Felicity Maris, who was a dietitian. All those people I've spoken to on occasion throughout my treatment. On the 12th of August, then, in that meeting, they told me that I had a squamous cell carcinoma of the right tonsil, and that surgery would be detrimental to me and may involve a loss of voice and other complications. There was a lymph node involvement, and the lymph node then was the lump that I could sense on the side of my neck. The following day, my wife was diagnosed with a problem. So we've had to live with a couple of problems as we've gone through. On the 7th of August then, at the BDH, I had some x-rays, and to my surprise, I had a couple of teeth extracted. This to make way for the radiotherapy later on. Osteoradionecrosis is a problem, I understand, so that was in preparation from that. I then went to the mould room and had this mask made. Some of you may be familiar with this. I became very, very familiar with this over 35 sessions and the following 7 weeks. So 35 sessions, as you see, of radiotherapy, about 20 minutes each session. 2 sessions of chemotherapy, one on the first Monday of the 7 weeks and one on the fourth Monday of the 7 weeks. First session of chemotherapy, I think I tolerated fairly well. Second section of chemotherapy, I really learned what chemotherapy was all about. And the latter part of my treatment, including the radiotherapy, then became quite an issue, I think, then. Several MRI scans in between, just to add to the fun, and an audiology test on a Saturday at Southmead Hospital, because I'd already had a fairly low level tinnitus, something which is an industrial noise thing, I think, for me there. So during my 7 weeks of radiotherapy, every Thursday I met with a lady called Vicky Brown. Vicky Brown was one of the radiotherapy nurses there. She made sure my medication was in order, made sure that I was eating properly, although that became more and more of a problem as I went forward. And a blood test each Friday just to make sure that things were on track and on the level there. And on the 17th of October, I rang the end of treatment bell. So that old man you see on there is me. Quite an emotional day, as you can imagine, there. And by that time, I was feeling fairly ill, I think, would be a fair assessment. Post-treatment, they'd already told me in that initial meeting that post-treatment, the first 2 weeks after radiotherapy would be the worst. More like 3 weeks, going on to a month for me. Sickness was a constant daily issue. Constant fatigue, I think. Skin burn, which was cured with a special application and took some time to disappear. I was unable to eat anything really sensible, only soup, and I had to force myself to eat that because I had no appetite whatsoever. Couldn't brush my teeth at all, especially with something that was tasty, so I had to use a non-flavoured toothpaste to manage to brush my teeth. Daily nausea, didn't feel well at all. Constipation, which is still with me on occasion. And over, I guess, the month following my radiotherapy, my total weight loss was up to 35 kilograms. So I've put a little bit on since, as you may notice, which is not a bad thing, I guess. On the 1st of December, at the Head and Neck Oncology Clinic, I met with a gentleman called Matthew Beasley, Dr. Beasley. He said he was going to follow my case through, and he effectively would coordinate some of the treatment in the future there. That was a face-to-face meeting. And on the 16th of January, at ENT, I had another nasal endoscopy, and some good news was presented to me at that time, that there was no visual reoccurrence of the cancer within my throat, which was, for me then, part of a sort of targeted progress, I guess. In January, I made some telephone calls to Rob Buller of Macmillan regarding a little lymphedema that I was developing here. And Rob then arranged for me to go and see the Sirona nurses down at Portishead to have that lymphedema looked at more closely. And I have daily exercises to deal with that, some of which are quite amusing. I won't perform them for you now. On the 18th of February, 4 months after my treatment with radiotherapy, then I had a PET CT scan at Southmead. That revealed a couple of lesions. One was on my left femur, one was on the T1 vertebral spine. On the 23rd of April then, as a result of that, I had a telephone call from the trauma and orthopaedic department at the BRI, a fairly urgent call. It seemed to be encouraging me to come in and see a gentleman called Niall Sullivan without further delay. So on the 28th of April, just 5 days later, then I went in to see Niall. I now know that Niall is a top hip surgeon in Bristol. He told me in no uncertain terms that there had been this lesion spotted in my left femur, that the lesion was probably a cancer, and that the cancer had probably originated here. So at that time I was seeing a stage 4 cancer, which had strangely gone from there to there, which in layman's term, and I am a layman and that sort of thing, looks a bit bizarre. In order to check that as a reassurance check, Michaela Goria, who's here today, arranged for me to have a further MRI scan on this side of my head, just to check that in actual fact it was a bypass and it wasn't something that had become a sort of stage 1 transfer. Things started to happen a little quickly, as you can see there. 28th of April, I saw Niall Sullivan at A312, had some x-rays taken, had that conversation with him that suggested that should I fall and should I break that femur, I can remember exactly what he said. He said, we will be in serious trouble. So I felt then I had no alternative then other than to have this operation to insert a titanium nail down into the femur, right into the knee, where I'd already had an operation years before to replace that total left knee replacement there. And on the 5th of May, I had a phone call from Niall confirming that operation would go ahead. On the 6th of May, I went to the BRI for a pre-op and a general discussion. It was then I found that there was a system in place then which was gathering patient information a little bit more accurately than maybe it had done before, because we were transferring between the BRI and Southmead for the surgery. On the 8th of May, I had an oncology phone call with Donna, one of the head and neck nurses there I'd become quite familiar with. And she discussed what was going to happen, what may happen in the future regarding the lesion on the spine. But this was the first step in maybe a fairly lengthy process. So on the 11th of May, 2026 then this year, I was admitted via Gate 21 Level 3 into Southmead Hospital for that titanium nail insertion. And this is slightly post-operation with a little bit of bruising there. The surgical scars have healed quite nicely. On the knee, you can just see through a few sort of souvenir scars I have there. I was transferred from the surgical centre there over to the new Bristol Surgical Centre at Southmead. The only problem I think I could discuss regarding the visit to Southmead was that I was invited in for 10 o'clock and I didn't go down to surgery till about 5:15. And I was sat waiting for some time. I was kept updated with the person before you, there's a problem, the person before them, there's a problem, etc., etc. But it seemed quite a lengthy time. And considering I hadn't eaten since 7 o'clock before, by the time I went down to surgery, I was fairly hungry. And the theatre there was really, really cold. They thought I was frightened to death, but I was actually shivering because of the cold there. On the 27th of May, I had stitches removed in the BRI. 28th of May at ENT. Again, I saw Michaela. And our visits now have become not 6 weekly anymore, but 8 weekly. Because again, she reported there was no signs of reoccurrence in cancer in the throat. 11th of June, I went to Brookley in Brislington to see Sirona there for a physiotherapy catch-up. I think Noel and his team had arranged for me to go there. And on the 15th of June, D401 Oncology, I met again with Matthew Beasley, who gave me my second bout of good news, which was that during the surgery for the insertion of the titanium nail, some samples have been taken of the reamings there. and had come back and proved to have no cancerous cells. And I was expecting to be told that's a stage 4 cancer and we're going to, treat it in the following week. So that was really quite good news on that day. 26th of June then, I had a telephone call from oncology to say that PET CT scan would be rebooked for me at Southmead. And that PET CT scan is due to commence tomorrow. Okay, so in terms of notables on my way through, I've had 80 hospital visits, dental hospital, BRI, various departments, oncology, etc., Southmead, and a number of other places for Sirona Care and my own surgery at home. From Macmillan, the notable people there would be Rob, Donna and Lizzie. All these people are really, really interested in me as a person. That's how it comes across to me. In radiotherapy, Vicky Brown every Thursday would check my progress, check my weight especially, tell me off for not eating properly, etc., but really monitoring me until she signed me off at the end of treatment. Michaela Goria talks to me in a very straightforward way and always knows about my case notes, my case history, and will answer any questions that I may have at that time. Lisa McNally and her team at the Bristol Dental Hospital, and due to have some implants put in there then on there again on Thursday of this week. And Dr. Matthew Beasley, obviously from oncology, again is a person who keeps me well informed on a face-to-face basis. Noel Sullivan, probably the person who spoke to me most directly, because there was no beating about the bush. If I fell and I broke the femur, serious trouble. And I appreciated that. I like that information. In Rowan, Lucy, the nurse in charge on the day, was quite informative, understood why I was there, what I was going through, and explained to me quite simply what the process would be for that day in terms of doctor visits, medication, checks, etc. The release from Rowan was perhaps not so good, and we weren't informed at that time that there was a pickup facility outside. So the discharge for me was a little bit of a slow laboured process, and I did end up going across the car park on sticks with a nerve block still effective in my leg, which was kind of interesting and challenging at the same time. In terms of radiotherapy in the BRI, there were constant delays. I had 7 weeks of constant delays, 35 sessions. Some people were becoming quite frustrated with that. Out of the 5 LINAC machines there, the linear accelerators, only 3 would be working at any one time. They're very complex machines, very expensive machines. Sometimes I think the repairs could only be undertaken by the manufacturer. And I did appreciate there that a gentleman called Josh, one of the nurses there, was doing his best to sort of placate any worries that people had. There were people there who were far worse off than me and obviously needed looking after a little bit better than me, I think. My impressions then from radiotherapy was that there are constantly more people than I ever imagined going through that process. I was astonished by the number of people that are going through there. And twice during my treatment, I think, I was treated in a very, very procedural way. I didn't mind that, others might. And I think there's a reason for that. The chemotherapy was very procedural. Most of you will know that your dosage is by machine. So you're put on for an hour, you're put on for 2 hours, you're put on whatever it is. And obviously there's a number of people in the rooms and the nurses are fairly busy. So it is a procedural type of event. And obviously the PET CT scan at Southmead also is fairly procedural on the basis of you have to be left alone for an hour for the radioactive material to work. And really people don't want to be with you whilst you're radioactive. So it is a little bit of a sort of lonely situation there. In summary then, overall, my impression of the NHS is the treatment I've had has been absolutely brilliant. I recognise that there are limited resources. I recognise that in some circumstances, the various departments are very stretched. However, the coordination between my various departments that I've been to visit has been fantastic. Everybody knows where I am in the scheme of things. Everybody seems to know about me personally, which I've appreciated. Grateful for the treatment and care that I've had. Very grateful to my wife for attending most of those 80-odd sessions over the year. I'm left now, I think, with tinnitus at a fairly high level, which comes as a screaming from time to time. And swallowing is quite difficult. Taste has completely disappeared in some respects. This actually is lunch at Rowan. So taste disappearing may or may not be a good or bad thing. Thank you very much for listening. I know I've rambled on a bit with all the dates. I'd be prepared to take any questions that you may have.
Fantastic. It was a brilliant story. Thank you so much, Roger. Colleagues, anything that you'd like to explore with Roger about his experience or any learning?
I'll go in with it. So thank you for a fantastic story and for presenting it so well. You've pretty much experienced every part of our complex NHS system, haven't you, as you've gone through your journey? And even so, 80 visits seems an astonishing number. And I suppose the question is there any way, having been through that you could advise us how that number could have been reduced in some way, or how we could have made that easier for you to attend those activities, but nevertheless, even if that was perhaps virtual, for example? So
virtual would be good, I think. A Zoom or Teams type thing might be good. I prefer face-to-face, to be honest. I've got all the time in the world because I'm retired, so a bus ride into town and walking up to the various surgeries is not a problem for me. Some of those visits could have been pricey down into a face-to-face Zoom call, telephone call, something like that. So I have found myself on occasion waiting around to have just a few minutes talk with someone. But even that I find it is reassuring. Certainly with ENC, if I go and see Michaela, I have to go in person and that sort of thing. I find really, really valuable. So for me, I don't mind that face-to-face interaction. Other people who may still be working or have busier lives than I have, yeah, they may appreciate that sort of pricing down of the situation, I suppose, yeah.
good, Steve, me.
Thank you very much, Roger. I just wanted to ask, obviously you have your lovely wife and your family around and friends. At any point were you offered other sorts of support or, associations or ways of extra support should you want to use people outside the family?
I did go early on in the piece to a presentation by Macmillan, sort of first steps presentation. Which I didn't find very useful because I'd already done a bit of research and I'd talked to other health professionals who'd sort of filled me in really, really well. Macmillan I was aware of as being in the background, and when I've needed them and I've gone to see them and said, I still don't know about T1, I still don't know about this, they've found out information for me and I've received phone calls back. I didn't want to bother too many people too much because I thought I was managing my situation really well. But when I have needed Macmillan, they've been there superb. All I would say about Macmillan is, for me, when I've seen their online videos, I've found them quite depressing. But that was a personal thing. Other people might find them really informative. I'm the sort of person who sort of self-taught and self-learns, so I can find out things that I need to know. If I need to know anything, I know there's professionals that I can call. Other people may appreciate that support, and many people do use Macmillan in 401. When I go to oncology, there's plenty of people there.
Steve.
Sarah. Thank you, Roger. Thank you. Just in terms of you clearly went across the BRI in Southmead. Did you have to kind of re-explain to people why you were there and what you were needing to do? I'm just checking to see if our digital systems are working.
No, I don't think I actually explained why I was there. I sort of expanded upon my story once I got to Rowan and I met the nurses there, and particularly the representatives that Emily uses there, because they were interested in, why are you here? Have you fallen? Have you done this? So they weren't aware of my previous story. But anybody from a professional point of view seems to have been well informed about my condition and where I was in the scheme of things.
Thank you.
Don't follow up, Sarah. I'll cover what you wanted.
Thank you. Thank you very much, Roger, for a really frank and really helpful story. So I really appreciate that. I was interested in what Steve asked you, so thank you for answering Steve's question. But I'm also interested in whether you found that each person you met gave you the time and respect that you needed, or you've been very complimentary about many people, but we have huge numbers of staff and not everybody understands necessarily why patients are there or what they're going through at that time. So has your sort of overall impression been of the organisation, has it been one that has felt welcoming or friendly or a word like that, or would you use a different sort of word?
No, I'd say welcome and friendly, certainly. I think I've been dealt with by people at a very senior level. So these people tend to be a little bit more experienced and a little bit more aware of the best sort of way to treat patients. The only comparison I can make is when I had physiotherapy for my knee at Practice Plus, which is effectively a private hospital, but I had that surgery on the NHS. The physiotherapists there were very, very professional in their approach, very, very informative. Do these things, don't do these things, and made sure I went through the process fairly well there. The same as Sirona and Brislington. They were very, very good at checking what I'd had done and how able I was. A little less so, I think, at Southmead, where some of the equipment I thought was a little bit too small for me. I'm a rather large person, so the equipment was what was in the room. And I don't know whether the physiotherapist there expected me to be able to walk straight away, whether that's a normal thing. I did explain that the nerve block was still effective in my leg, and I couldn't feel the lower part of my leg even when I left. But I think the physiotherapy there was less professional and less effective, and maybe more procedural than I'd experienced before. I understand with the chemotherapy side of things, there is a process and you have to be left for certain periods of time. And again, with the PET CT, and I'm the sort of person that accepts that because I like the technical side of the sort of thing. So I can understand why that is. But most people have been really caring, professional and welcoming and really keen to learn my story, I think.
So, Roger, thank you. You've explained this amazing journey, which Emily, I think we found out about through the real-time feedback, which happens through volunteers. So people who themselves have used services that just spend time talking to people and finding out what their experience is. So it's great to hear some of the output from that, Emily, as well. But Roger, you've described a journey which, as Steve said, has touched pretty much every bit of the NHS around here. Whether that's GPs, Sirona, you talked about a private provider as well through the NHS, Southmead, BRI, dental, you've seen it all. Yes, there may have been one or two things that might have been less procedural, but overwhelmingly what I'm hearing is it was seamless, it was coordinated, people knew who you were, you felt treated like a person, the communication was good. You didn't have long waits. So I think we can take some encouragement from this, folks. We don't always get such good news stories, I might add, round this table. But I think for today, that has been a real encouragement to us.
Pie looks good.
That pie looks good, yeah.
Chicken and mushroom, apparently.
Better than soup.
Just tasted like everything else tasted.
Maybe I can find.
But you've moved on from the soup, haven't you? So, yeah. Great, lovely. Well, thank you so much, Roger, and thank you, Emily. And before Roger's story, I omitted to ask about any declarations of interest. So are there any declarations of interest today need to be noted? No. Okay, in which case, let's move on then to minutes from the 12th of May. Any amendments? No? Okay. In which case, are there some matters arising? Yes, there are a couple. But no actions to be live today, I don't think. Just something about the Green Plan, action ongoing about a board seminar on that, Freedom to Speak Up annual report. We're going to get an update in November. Are there any other matters arising people have noticed from the minutes? No? Okay, so we'll take them as a fair record and move on to questions from the public. And we do have a public question, but I don't think Amanda is with us. No. So perhaps, Lavinia, you could read the question that we've received, and I know that Glyn is ready to make a response, which will obviously be passed on to Amanda. So over to you, Lavinia.
Thank you, Ingrid. Board members, you'll have the question and the response in your packs today, but for the benefit of the public observers. This is a question received from Amanda Bryant. Her question is, I would like to discuss the fact that the Union flag is no longer flown at Cosham Hospital and hear the reasons why. There are various reasons, rumours circulating, and would like the chance to talk about why it is important to the local community and find a way to have it reinstated. It is a fundraising tool for the hospital, and I am not sure this is a known fact. I have a petition which has been done face-to-face and not online, with over 1,000 signatures in support of the flag and the ethos behind it being flown. I have been to the hospital and spoken to staff and contractors on site, so feel I may be able to explain and discuss any issues. The flag being flown at the hospital is not related to any political views. It is a flag on a designated flagpole to celebrate and commemorate people whilst raising funds for the hospital. I'll now hand over to Glyn Howells for a response.
Okay, thanks. So no flags are currently flown at Cosham because of safety concerns around accessing the flagpole, which is on the roof of the hospital, and it is no longer safe to get access out onto the hospital. We are working with the League of Friends regarding the replacement of a flagpole at ground level, which would be safer and easier to access. Planning consent has been sought and is being waited on. Once that's in place, we'll work with the League of Friends about how we reintroduce regular flag flying there.
Okay, thank you. So obviously we will pass on that information to Amanda, and she's asking for a discussion. So if she still wants to have that, I'm sure we can facilitate that in due course as well. Are there any other questions from the public today? Okay, thank you very much indeed. We will move on then to Chair's report, which I will largely take as read, but just pick out a few points of note. First of all, visits. I've been on a tour of the joint services, the group services, and it has been quite fascinating to hear about the realities of how those are rolling out. And overwhelmingly, the stories have been really positive. So just the other day, I went to cardiology, I've been to pain, I've been to trauma and orthopedics, the community participation group last time, heard from therapies. The positivity that is coming through those visits is really, really strong. Of course, people are wanting to know what next in terms of how the merger is going to support their work. You know, I was talking to Paula earlier, really practical things about, you know, when are the budgets actually going to come together, the kind of real life integration of some of our corporate systems and so on that will assist them further. But yeah, really interesting and positive visits. And Sarah and I also went to visit St Michael's maternity and neonatal units. Really, Sarah's one of our 2 maternity champions. And again, in the light of the national stories about maternity and all of the reviews which are mentioned later in the papers, I think we felt very assured that the compassion and the care that is given to women in those services is really very good. So that was good to see. I've been out and about with partners and stakeholders as usual. Been doing locality visits and sorry, I've got the wrong page here. Bear with. Yes, so lots of visits to partners, some really interesting work going on with our own group partnership event. I went with Mark to visit the Innovation Centre at Frenchay Campus. It was really good, Mark, to see the amazing work that's going on there. I know lots of you will be familiar with it because we have many joint appointments and visiting professorships and so forth. But it was really excellent to see that. So thank you, Mark. It is the future of healthcare. Amazing stuff around robotics, wearables, AI. So yeah, a look into the future. Maria and I went to the national conference of NHS Alliance in Manchester. It is the national conference now. There were thousands of people there. And I had the pleasure of speaking at the conference actually about the learning from being a group and what that was like. So that was an interesting opportunity. Also, South Gloucestershire Health Overview and Scrutiny Committee. Tim and I went to visit them. Interestingly, they did raise the question about the site at Prenshey, which is something I know we're going to have to pick up because we do own that land and it is of particular interest to the South Gloucestershire community. But we were really there to talk about the merger and the benefits that it will bring for people. And we got a overwhelmingly positive reception from the HOSC there, as indeed I think we have with the other two health overview scrutiny committees as well. Continue with MP visits, most recent one, Glyn and I met with Claire Hazelgrove. I think I might just leave it at that. The rest of it is in the paper for you to see. So yeah, open to any questions. I know that Sarah and Martin have also got aspects within the report. And then finally, there will be a recommendation that I need to ask you to approve. But I'll just pause there in case there are any other points. No? So the approval then is for Sarah Purdy, because Sue has been our senior independent director until now, but with the merger becoming a single trust, Sue's imminent departure at the end of her term, the proposal is that Sarah Purdy is now appointed as the senior independent director for the trust. So are people happy to endorse that proposal? I know that Sarah is very much trusted and respected by all of us and would be a sound source of advice and wisdom and independence should it ever be required. And thank you to Sue for all you have and are doing still as you come to the end of that work. Thank you very much. Are we happy to endorse? Yes. Great. Thank you very much. In which case, I think that we can move on, Maria, to your report.
Thanks, Ingrid. Similarly, it's a written report, so I won't go over everything, but also wanted to acknowledge that as of 1st of July, we are now a fully formed trust. So it is a historical moment, actually, big milestone for everyone here on our 2 years of work. But just wanted to acknowledge where we hope to get to as well. I know we keep saying the hard work starts here. It does, actually. We have 4P benefits now to deliver, and we will be monitoring ourselves, obviously at board level, but certainly our regulators will be too. And part of the ongoing discussions, because it's a fairly vague world when it comes to both regulation, but also CQC, NOF frameworks, how as a single organisation we are going to be viewed. So there is a lot of discussion that is beginning around that. I also wanted to reiterate the incredibly positive feedback. I hope colleagues all felt it on the first day or two, and to thank you all for your participation in going out to see staff, to hear from them, to talk to them and to reassure where we could. But great energy and goodwill. The day went very well. So as I say, very grateful. Leading up to this moment, and also to everyone who supported it, the estates team who'd run about changing all the signs, the comms team who had put a lot in place as well, and everyone else who'd been involved. Some national topic, as Ingrid mentioned earlier, a lot has happened around maternity in the last couple of months. So 2 big reports, the AMOS report, where we've had 10 priority actions, part of a broader national action plan, which will be coming out later this year. We're currently going through the assessment where we our own both self-assessment and maturity undertaking for how much more we need to do. Some interesting recommendations both around Martha's Rule, but also the dual board level accountability between CMO and CNO. So that will be for us to work through. Similarly, Ockenden, Donna Ockenden, and the review into services at Nottingham, published also in June. Again, we will do our own consider review of these recommendations just to make sure lessons learned are incorporated in our operating procedures, patient experience, etc. going forward. Within that, there were some issues, particularly around Human Tissue Act compliance. So again, we maintain oversight. They're part of our regular visit schedules, talking to staff. And we will be making sure the existing compliance arrangements support any recommendations. Lord Mann Review obviously has offered a comprehensive programme of recommendations around addressing anti-Semitism, wider forms of racism. Some positive news around resident doctor industrial action, where a deal has been struck. Which, you know, I think is wonderful news, and we continue to review our 10-point plan for resident doctors and how they interact at senior leadership level. Obviously, we have also been advised about a potential consultant industrial action going forward, so we'll continue to plan as required. I think the minimum standards of patient experience have now been published. I know a number of us have been part of an advisory group with Danny Mortimer on how these have come into being. They seem sensible. They've had lots of engagement, and of course, as Steve and the team develop our quality management system over this year, we will ensure that we incorporate the expectations around this, so we have a regular checkpoint. I will just mention operational performance. We have had heatwave planning, so it has been very unusual in that we've had red weather warnings for some time now. We've had critical incident declared at the Southmead site. I am aware in this report that we're a little bilingual as we refer to sites and previous legacy organisations, depending on which bit I'm talking about, pre and post 1st of July. So that will fade out over time, of course. Number of partnership events. It seems a while ago now, but we had the chair and executives and non-executives attended a partnership event back in May. Again, good turnout to talk about how we work increasingly with our partners, which are very wide-ranging across our locality. Reaccreditation for the Tessagel Centre of Excellence. Do just want to acknowledge expanded leadership role of Julian Thompson in the Major Trauma Network, which I think is absolute testimony to how well thought of the Bristol's clinical leadership to high quality trauma care across the region is. Again, Scott Greer and his role in critical care transfer service with Retrieve also acknowledged, and wanted to just pick up a couple more appointments. The new chief pharmacist appointment, John Standing, so congratulations to John. Also to Becky Thorpe as new medical director at our City and Western site, and huge thanks from all of us I'd like to convey to Becky Maxwell, who left us last week finally, but she did an incredible job here. Claire Davis is our new JUC chair, so I'd like to offer our congratulations as we work with our union colleagues. Really important part of all the transformation work we know we now need to do going forward. Would also recognise the NHS Confederation seems to get bigger every year, even though they are now a combined. I suppose that's the case. They're now going to be an alliance, so it will be two organisations coming together. There was something similar, although it was over in Amsterdam. It seemed to have a lot of the same clientele who'd been at the Confed, Penny Dash and lots of others were over at the Health Tech conference too, and both I was doing sessions at both of those. Range of visits which are documented, and happy to take questions.
Great. Thank you very much, Maria. Any thoughts or points that anyone would like to follow through? Sue?
Thank you. It's probably a question for Steve, actually. I wanted to go back to the AMOS report maternity. A couple of things. Given that we were a pilot site for rolling out Martha's Rule, can you give us a kind of indication, will we be able to go earlier than planned with Martha's Rule? And were there any surprises or things that you're concerned about that we should be aware of in the recommendations that have come out of the report?
Yeah, thank you, Sue. So in terms of Martha's Rule, we will use the experience we've had, particularly in paediatrics. The children's team have done a superb job at rolling out Martha's Rule. So we'll use that expertise in terms of maternity across both, I was about to say both organisations, both hospital operating units. I'm going to get used to that, HOUs. So we'll use that experience. In fact, the teams have been working together already. So my hope is they'll be able to move fairly quickly. In terms of surprises, not really. The team, both maternity teams, a couple of weeks ago came together. Stu facilitated a session with Tim and Glyn and I as part of the group clinical services, but actually we took the opportunity to look at both reports, and we'll use both reports as the lens upon which to build the team together. So as Maria was saying, we're just reviewing our overall assessment against each of the recommendations. Of course, the recommendations are not national recommendations yet. NHS England will publish those towards the end of December, but we're taking the opportunity just to look at them. I think personally there's no real surprises in both, but notwithstanding that, I think it's fair to say that some of the experiences that women had both in Nottingham and through the AMOS review are pretty shocking. Let's say the team are taking a very thoughtful look at what the recommendations currently say.
Okay, thank you. Jenny?
I was just going to cite the board on the Lord Mann report. So we've a deep dive on the race and the disability data at our People Committee this month. The team are doing a gap analysis against all of the recommendations in the Lord Mann report. I'd really encourage us, I think, to be looking at improved outcomes rather than the activity that we undertake in order to be able to try and address discrimination in the workplace and with regard patient care. In private board, you'll hear this afternoon a story about a really proactive member of staff that very thoughtfully coached a patient who had been discriminatory towards a colleague. So you'll hear a fabulous story this afternoon about how we keep talking about this being a leadership issue, and you'll see that leadership demonstrated in that story this afternoon. Obviously, we've got Black Maternity Matters coaching us around this matter as a sort of a board development topic, and quite a big board development topic. But what we'll make sure about is when we do the gap analysis through People Committee in September, we'll just make sure we're really clear on what is it that we need to ensure the board is cited on and doing, if there is anything over and above what we are already doing. So just going through that process at the minute, just to establish whether our plans are coherent and completely aligned, or whether there is anything else we need to be doing.
Okay. Thank you for that. Good to be cited on that. And yeah, we're doing a lot of work in that space. Look forward to hearing the story later. Thank you. Mark?
Yeah, one's a comment, one's a question, Maria. Comment, really delighted to be involved in the start of the new era on the July the 1st. And I think hard work done by many. I was with Glyn for a short while, giving out new badges and lanyards, Glyn. We had a bit of fun, didn't we? It was great. And 99.5% of all the people we came across were really positive, really engaged. It was just fantastic. I wish I could have stayed more, but I couldn't. But it was really good. So well done to all involved in terms of the comms, the organisation, and just the effort, really, I think, on the day and beyond the day as well. Second one, I think great with the app with the new appointments as well, and I've got a particular kind of lens on the joint pharmacy role, and just really thinking about where that then starts to drive forward that, because previously we talked about innovation in that space, haven't we, and even the word commercialization, if I'm being honest with you, where we started to take that forward as a joint initiative. I didn't ignore the other ones, but I was really focused on that one. So anything you could say on that at all?
I think there is a absolute expectation, so that role will be sitting with you, Tim, isn't it? How we, there's lots we do around some of the commercial aspects already, but I think we could do a whole lot more. Some of the partnerships, and obviously we'll be working both with yourselves and with the University of Bristol on much more the research-focused outcomes and the applied research outcomes. So again, this new appointment will play a key role in that.
Okay, Roy.
Thank you, Ingrid. Maria, you mentioned hot weather there briefly, so I just wanted to ask, given the heat waves in the last few weeks, what's sort of been our experience of it, and more specifically, the guidance that we have for staff across different sites, different clinical specialties. Has it worked? Does it seem like the guidance which staff knew what to do under which conditions and so on, or are there any learnings from it? Because this is not the last time we'll have heat waves.
No, and I would say it's been a mixed experience for staff, depending on the estate that they're based in. Unfortunately, some of our infrastructure, and I think this goes right across the NHS, is not resilient for extremes of weather, be it very cold or very hot. Of course, we will mitigate through bringing fans in, hydration, opening windows, darkening rooms where we can, trying to, of course, allow staff where schools were closed or nurseries weren't available to try to work their hours round, but taking in the fact that we are a 24/7 service. This has been a sustained period for us, and obviously the critical incident, I think, was not necessarily at the first bit of heat, it was 10 to 12 days afterwards. So that curve where people are experiencing their respiratory and cardiac crises as a result of being under sustained stress. So they're the sorts of things that we've been having to deal with. So my commendation, because as we know, for people without aircon, it's been verging on intolerable. So I think, whilst we can't go out and build a whole new raft of hospitals, it's certainly been acknowledged at national level that this is something that we are now going to have to put much more capital in. So there's been discussion about a 3 billion capital programme now, not just in relation to this heat spell, but a further commitment to reinvigorate the new hospital programme.
Yeah, thank you. If I could just follow on very briefly, I was thinking more about the policies and the guidance. Are staff clear about what, the estate is what the estate is, and you can't change that overnight. But from a clinical safety and patient safety point of view, there are certain things that staff need to do or not do based on what the temperature is. And is that guidance and policy clear, or do we need to do some work on it at all?
Do you want to come in, Glenn?
So there's we have SOPs for heat waves, and so those things are there. Both sites ended up standing up what called a business continuity incident, which is where we sort of put the faster metallic structure in place behind the scenes, so before critical incident, to start to make decisions and be more reactive. So that so on the Southmead side, that resulted in us reassessing which sites were getting thermal gain, so moving some temporary air conditioning units around to make sure we're protecting the sites that are there. We have SOPs that sort of go out, so a uniform policy: wear shorts if you need to wear shorts, hydration, making sure all those things are there, and getting the messaging out, reinforcing all of that. But that business continuity incident just gets regular fast flow reporting of real-time data to allow you to be a bit more reactive. And that then gave us the signals that for us, we knew when we went into the critical incident, we were having to provide care for frail elderly patients in places that were getting thermal gain, and it just was clinically not appropriate. So we needed to do something to sort of pull the trigger and do something outside the norm. So we've got SOPs in place. They're recommunicated. We put fast flow information, real time information there to be able to allow decision making to be done, and we keep communicating.
Does that help more?
Yeah, thank you.
Neil?
Yeah, I was just going to add, we know that on our planner for the board, we've got a session on sustainability to come to a board seminar, and I was discussing with Sam Willits last week that will include the inevitability of future heat waves as part of that discussion, including the extent to which changes in temperature can be predicted in terms of likely inflow to hospitals. So that'll be part of the session that we plan to bring in the near future.
Okay, so more of this when we meet to discuss the green initiatives that we can get behind. And I noted that WECA have reached out to us as well, haven't they, on wanting to do some joint work around climate. Okay, lovely. Anything else on Maria's report? This isn't a meeting where we take questions. I'm really, really sorry, apart from in the public questions bit, but could we maybe pick something up we're about to have a break, so we could pick something up then and reflect it into the room afterwards. Is that okay? Great. Thank you, Michaela. Appreciate it. Okay, shall we move on then to the Bristol and Western Hospital Charity Report? And I believe this is Stu and Glyn presenting.
He's going to pick it up.
Okay.
So I'll pick this up. So I'm happy to say that the transfer of Southmead Hospital Charity into Bristol and Western Hospital Charity went as planned just before MBT ceased to exist on the 30th of June. So that has all happened. As per all the papers that have gone through previously and have been approved through the Charity Committee and Board, we had proposed that myself and Stu were going to be the nominated representatives, so the nominated trustees on the charity. As we've gone through the details of this, Stu feels that it, as he also has a lot of dealings with the Grand Appeal, it is better for him not to be conflicted, and so it also provides that Sarah Dodds could provide some continuity because she's been acting as the trustee there. So the proposal here is, I guess, a quick update to say everything happened as planned, but a slight tweak. We're proposing now that I represent Southmead site as part of the trustee, and the Sarah Dodds continues from the City and Western site.
Okay, thank you, Glyn, and good to hear that transfer of Southmead into the other charity has done successfully. So thank you for the work on that, because if board colleagues will remember, it was technical and difficult, so appreciated. Any thoughts on the nominations of Glyn and Sarah as our appointed trustees to Bristol and Western Hospital Charity?
Fully support.
Are we happy
Sensible.
to support that nomination, those nominations? Okay, thank you. And thank you, Glyn, and please pass on thanks to Sarah for picking that up for us.
Will do. And can we update the register of interest that will now a trustee at the Bristol and Western Hospital Charity?
Brilliant. We are slightly ahead of time, but as the next item is quite a lengthy one, I suggest we do take our 10-minute break now. Oh, beg your pardon,
we're just
Vic,
saying
we
that
didn't see you.
the volume here, we're struggling to hear.
Oh, you can't?
But yeah,
Okay, so we need to
yeah.
project more. Sorry, thank you for
No,
letting
that's
us
okay.
know. Okay, so voices up, everybody. Speaker's corner. Yeah. Okay, we'll take a 10-minute break then, and then we'll come back to look at the Integrated Quality and Performance Report. Thank you. I will try and project even more. Sorry if it sounds like I'm shouting. Integrated Quality and Performance Report. And I'm going to turn first of all to Stu and Glyn to pick out the main themes around responsiveness and access. So over to you.
Thank you, Chair. So I'll kick off if I may. So just the report goes up to May, but of course the summary I can give does cross the transitory period between us being two independent organisations and a merged organisation. And I think as is the point you made earlier, Ingrid, there will be some degree of iteration of terms and reporting lines and so on over that time. I think it's also worth flagging up, just for people's information, that in terms of our regional monitoring of our operational performance, the regional monitoring meetings have now commenced, and so we do now have that system in place. These are routine, monthly. Every trust is having them across the southwest, and we've had our first one. And so it was actually useful in terms of getting an understanding of the key metrics which are on the regional page in terms of areas that we really need to be looking at. And the good news is that, of course, the ones that we predicted and we know about are indeed the type of areas that were looked at regionally. Going through our current performance, if you go through the IQPR in terms of all of the areas, things remain largely steady. But if we go into the detail, under urgent care, the THP remains in place, and so of course our 45-minute performance remains very satisfactory. Demand overall is above predicted. Now that has not been felt equally across all of our sites, and I won't speak for Glyn here, but I think that has been felt to the greatest degree on Southmead site, to a degree on the BRI site, and perhaps to a lesser degree on the western side. That, of course, results in a challenging environment, and therefore the 4-hour performance standard remains challenged. We are working closely with all partners across the system, not just in terms of our immediate response to that, but also in terms of our planning now that's going into place of how we can respond for the rest of the year and specifically over winter. And so I want to be quite positive about that and say, actually, we've been working closely with the system and have got positive actions in place for looking at the delivery of 4-hour performance over the rest of the year. I won't go into detail because some of it's not totally confirmed, but nevertheless, I think we are in a better place in some of those areas. Of course, we've touched upon the consequence of the heat in terms of emergency demand, so I won't go over that again. I suppose the one point I will make that hasn't been made yet is it's well recognised that during times of extreme high temperature, demand goes up. In terms of the type of vascular things that Maria mentioned, in terms of direct temperature-related illness, in terms of frailty and the knock-on consequences of frailty. It's also recognised that then when the temperature drops off, that demand can then drop down a bit. But in fact, that rebound has been there, but it's been less pronounced than perhaps at other years. And so that higher demand has persisted to a degree which has had an immediate operational consequence. As you can therefore see, this is of course data from before then, but it is still the case that we remain challenged in terms of our 4-hour delivery, 12-hour delivery, corridor care, etc. In terms of, I will just mention the corridor care. As you can see, there's a really useful benchmarking slide in the IQPR on page 67 of Convene, which I personally find very useful. And I think a couple of key messages are that trusts are I think, using corridor care in different ways. So some are predominantly utilising an ED-based sort of escalation capacity strategy, and some are using a predominantly ward-based strategy. And we tend to be more in the ward-based camp than the ED camp. And work is ongoing between us and NHSE and other providers as well, looking at how we actually do define those ward-based beds in terms of corridor care. And so that has not concluded yet, but it was never really the intention of the corridor care definition to include bays in wards. And so as we work our way through that, you might see a bit of a change in that. We're hoping you do, especially as we are predominantly not an ED corridor care based trust, and we tend to use more ward based escalation capacity. In terms of no criteria to reside, that remains high, as you can see. Again, lots of ongoing work with the system and with the Discharge Advisory Group nationally, and actions in place. We are, of course, hosting the Intermediate Care Programme at system level, which has a number of subcomponents, P1 pathway being a key one, working with colleagues in Sirona, and long-term in terms of the intermediate care work, working with colleagues in local authorities. But at the moment, that we haven't really seen the dial shift on that. Now, especially for BRI site, the no criteria to reside consequence, of course, is felt across all our sites, but especially for BRI site with the loss of the 2 wards, that has then had an additional knock-on consequence. And that consequence is predominantly felt, actually, I think, for BRI site in elective activity. And so we're sort of moving on a bit from that unscheduled care arena into the elective arena. Overall, our elective performance remains strong. I think there is a concern that our total waiting list size has crept up over the last month or two. And that was one of the issues that was brought up in the regional monitoring meeting. I think we've got to watch this space a bit, because people will be aware that the referral management centre at ICB level, the function of that is reducing as the single point of access function comes online, but the single point of access function is being a bit delayed, and so there does risk being a bit of a hiatus between those two referral management processes, and that could have a knock-on consequence to total waiting list size in due course. So we're keeping a weather eye on that, working with the ICB on that, and that's something I know that they're taking to the highest levels within their organisation, which is great. Diagnostic-wise, we still have a knock-on consequence on our diagnostic performance of the Western Firing endoscopy. Now, the Vanguard unit is open and working. It did get affected by the heat and had to shut again on about day 2 for a short period, but is now up and running, and we're using that as much as possible to get some traction with reducing the additional waiting list diagnostic activity backlog. So that's really positive. We're also outsourcing for City and Western Hospital Operating Unit our non-obstetric ultrasound activity, which has been a bit of a pressure point for a while in terms of diagnostic activity. So we're outsourcing some of that to try and help with that. We also got a recent unexplained increase in CT demand that we weren't really expecting. So when we're looking at that, we're doing a diagnostic on that diagnostic demand to see where that's exactly coming from and what we can put in place to get that back to where we thought it should be. Cancer, I think one area of increased demand at the moment relates to obviously seasonal skin activity, skin cancer activity. That came up in the regional review of interest. So, of course, that's known about. We know that goes up over summer, but that does have a knock-on consequences to the numbers. But the main pressure point, certainly for City and Western, who remains in terms of chemotherapy capacity, and you can see the consequence of that in terms of some of those numbers. Of course, Board are cited on the fact that we have the chemotherapy unit coming online in South Bristol Community Hospital in due course. That is not yet in place. And because of some delays in that programme, we are now looking at an intermediate solution for using an additional area for temporary chemotherapy capacity to try and bridge us until the South Bristol Community Hospital capacity comes online. And we're also looking at what we could do at Western Hospital in terms of the satellite chemotherapy unit there and the day case unit there, which are sort of separated by a ceiling. But some of the activity that goes on in the chemotherapy unit there might be possible to go into the day case unit, thus freeing up additional chemotherapy capacity. So we're working through all of those types of things to see how we can improve their capacity pending the South Bristol Community Hospital opening. So a bit of a mixed picture really, lots of pressure points, but lots of activity in response to those. That's probably all I was planning on saying, and happy to hand over to Glyn and then take any questions as appropriate.
Thanks. Just a couple of things to add from there. The Southmead Hospital has definitely seen
Can you hear, folks? Can I just check?
No, go try again. The Southmead site is definitely seeing the biggest increases in ED attendances. So yesterday we hit 396, we hit 407 a couple of weeks ago. Previously the highest ever was 377, 378 in the second week of January. So we are seeing in excess of our winter levels appearing. So we're about 20% higher than our plan level per day. Many of those are frailty and the heat exacerbations of underlying conditions for frail patients. So we are not seeing this result in a statistically significant higher level of admissions. We're managing to turn patients around. But they are what we call non-admitted majors. So they are having 8 or 10 hours of care and then are being discharged home. But they did need to see us. This isn't a failure in primary care or a gap somewhere. These are sick people who need acute intervention. Interesting though, we are seeing a very full hospital. So if it's not coming from these higher admissions, where is it coming from? And no criteria to reside is still around 200 patients. However, the average time that they are with us, the number of bed days that each of those is creating, is increasing. So it seems as if there is a cohort of these patients who are with us for longer, which means the beds that are turning need to turn faster. And if they can't turn faster, then we end up with fewer discharges. So that's what's happening there. In terms of corridor cares, we had a visit from the national team because Southmead Hospital site is one of the highest recording of corridor cares, and that didn't feel right to us in terms of how we're providing that care. So we had a visit from the national team who said that actually for us around 32 of the beds that we are classifying as corridor care under the definitions that we've been given are actually should be reported as enhanced escalation planned escalation beds, because they meet 98% of the classification. So we've got to do a little bit around privacy and dignity, and then those numbers should reduce down. Notwithstanding, as I said, when corridor care reporting first came in, there are escalation spaces that we use that we're going to have to classify as corridor care. There are other escalation spaces that we do not want to use because we don't think that they are appropriate, or they start to compromise other operational flow. So we will continue to report those so we have full visibility of both those that are counted as corridor care, but also those other escalation ones, because it's an example of us being in extremis and doing suboptimal things. So I think I'll leave it there unless there's any other.
Thanks very much. So I'm going to pause there to take questions on this aspect in the report. So Mark?
Yep, thank you, Chair. Thanks, Glyn. Thanks, Stu. I actually went on a site visit to the ED department at the BRI 2 weeks ago, and we were discussing the after effects of the heat wave and similar stats down there. Glyn and Stu, in terms of admissions and things, and all staff working really, really hard and a bit knackered, I would say, from what had been the week before. Corridor care came up, and it wasn't any cases of corridor care at that time I was there on the evening shift for handover. But then we went into a conversation around SEMS, or the Community Emergency Medicine, or medicine services, SEMS, which I believe has been really positive. And there has been a case put forward to the ICB for more funding to make it a 7-day service. I was just wondering, because to me that's a no-brainer in terms of the work that they do, keeping out any potential referrals, or reducing them at least, for those that could have care within whichever setting it is within the community. I just wonder whether there was any kind of further developments or plans on this that we should be aware of, because it was a great discussion about how coming together with the paramedic services and a really holistic kind of piece of work to support the endeavours that we are trying to achieve.
Yeah. And I met some while ago with one of the consultants that
Harvey Payne.
operates that service, and it is really exciting, I think. Stu, do you want to respond?
Yeah, I mean, there are a number of services based in the community, which of which Kems is one, Frail Chase is another. I think it's recognised that the combination of those services, which have tended to have grown sort of as a single service rather than as part of a broader whole, could be improved. And I think the big win for us is a piece of work being undertaken at system level right now to coordinate all of those different components of those different services available in the community. And so to make sure that for every patient who requires support, there is a pathway that they can follow. Within that, it was recognised that some of these services are 5 day a week only, or 7 day a week, or other specifics related to each of those services. And my understanding is that would be looked at as part of that review. I have not heard specifically that there is agreement to increase KENS from 5 to 7 days, but I do recognise the fact that both the hours and days of those service workings would need to be reviewed as part of that coordinated piece. So for me, I think it still sits in a not yet decided pile, but it's recognised as part of the broader piece of work.
If I come back, that's right. Thank you, Stu. That's really helpful. In my report to declare, I suggest that someone come to present on where the sends to the port. I think you should hear it from them. There's a lot of coordination that happens. I think to my view is probably a bit informal. And then back to your point, Stu. This for me feels like a really innovation-led piece around how we come together and interview services to work with communities, work with groups to make sure that we're doing more specification as well. I'm not saying we're not if we come to hospital, but sometimes it's better with the deeper group in which they're to things like UTIs, etc., can be treated, effectively in the KHO, etc. So, if we could just have a little bit of a timeline, I suppose, in terms of when these things are being brought to the front in terms of who's doing the piece of work, initial bindings, recommendations, because there's a bit of a buzz around this, but equally there's also a bit of nervousness because of the where's it going, where's it heading, and the empirical evidence is suggesting, which they have from publications, from research, is that it works really well. So my challenge to us is how do we become a leader in this space?
Okay. So it's Tim, do you want to respond to that?
So I couldn't agree more. I've said many times admission avoidance is much more productive than trying to escalate discharge when patients are trapped in hospital. Perhaps later in the private board, we'll have a clinical strategy discussion, and the scalability of these, what have been pilots and projects, is absolutely key to one of our paradigm shifts. So we'll have a discussion later.
So a major piece of strategic thinking, and we will pick some of it up a little bit later. Martin, I know you want to come in, but I would just like to highlight to colleagues, we've used up pretty much the entire time allocated for this item, and we've got another big chunk of it to go. So over to you, Martin.
I can be brief then, because my question was going to be along the very same lines, which was, how do we stop, the people coming through the front door, frailty, whatever it is, and at what stage do we as a trust say, this is now one of our objectives, we're going to monitor it, we're going to measure it, and we're going to actually track and do some serious work to try and stop the front end as well as monitor the back end.
Yeah. And there is something about the operating model which is still fuzzy about whose job is it anyway, and I think that is probably part of the dilemma that we're facing. We can visit that later, perhaps. Yeah, and the work that Maria's initiating around further collaboration with provider partners, I think, is really important part of this, with primary care, with Sirona, and so forth.
I'll be very brief on that.
Go on, Stu.
the intermediate care program, one of
Yes.
the remits of it is very specifically pre-admission and rehabilitation. And so actually this is clearly within that remit, and
Yeah.
we are of course
And we have
hosting
the
that
mean,
program.
yeah,
Fab.
yeah. Okay, more of this anon then. Let's move on quickly. Steve and Tim, anything to pick up on the quality and safety element of the report?
Just a couple of things, and actually in the last 20 minutes, the National Quality Strategy has just been published.
It has, yes.
So we'll hear more about that in due course, colleagues. Just a couple of things from the report then. So patient experience broadly stabilising. The complaints response times, whilst in the report don't show much improvement, the improvement for the last month is though turning in the right way. There's been some focused work across both hospital operating units to improve compliance and performance. In fact, there's a deep dive coming into Quality and Outcomes Committee this month. So you'll be able to see some of the work that we have been doing. The key thing here is about sustaining the performance. As we know, we've had a couple of good months and then it drops again. So it's sustained performance. So that's encouraging. The PQSN and the PQOM, which are the maternity aspects at the back, they are the same things. They will become PQOM going forward. Just thinking about Ockenden and Amos, triage will be a new set of indicators that will have to come into board. And just to point you to those in this set of papers, attendance at triage. And again, this is our second ED in terms of our front door for maternity services. So both hospital operating units seeing close to 2,000 women a month through a triage service. Over 3,000 calls handled at the Southmead Hospital Operating Unit. So this is a busy, complex, tricky service, which will require more board oversight going forward as part of the national expectations. Just in terms of performance for May, though, for the Southmead Hospital Operating Unit, just over 1,000 attendances at triage with a 41% 15-minute initial assessment. Moving to the St Michael's one, over 600 attendances with an 80%. So there's a differential. And that's one of the differentials we've been talking about when we came together as two maternity services, about how do we level everybody up to the best. So learning from the work the St Michael's Hospital Operating Unit have been doing. So just to focus some of our attention there, I know that colleagues have been saying the PQOM and the PQSM is complex to read. It is. But we are pulling together a more coherent report for both hospital operating units, which I hope will be much easier for us to work through. Happy to take any questions on any of those aspects.
That's great. Thank you very much, Steve. Martin.
I suppose just to follow up on that point, the main report is really good, I think, with the what does the data tell us, what are the actions and what's the impact going to be going forwards. Well, there's none of that at the moment in the maternity, which I was a little bit nervous about given the various external reports. And so it'd be great if going forwards, as well as being easier to read, we could have a little bit of more impetus on what it actually means and what we're going to do about it, rather than just a presentation of the data.
The wraparound to this comes through Quality and Outcomes Committee. I think going forward, we'll just need to work through what comes into board with your support, Ingrid and Sarah, in terms of QOP. But there is a risk and a chance that we could become heavily maternity focused. It's a high risk service, but we do need to be mindful of what comes through.
So looking at the variation in friends and family test scores in the two units, and congratulations at BRI with 100% on the friends and family test. What's the learning? Because there was a big disparity there, and how will we make sure under the new QMS and response to Amos and Ockenden that we are learning as quickly as possible?
So a couple of things just in terms of the data for the Southmead Hospital service. We have now moved to the same service that St Mike's is using. So there's a differential in service provider. So we were anticipating a slight dip in terms of overall performance. However, the feedback from women, largely from both organisations, tends to be around communication. The work that we've been doing around bringing the two services together, this has been a key conversation for them about women's experience. Now, you might reasonably say that two services 3 miles apart couldn't have been having those conversations years and years ago, but actually they are now creating the environment for them to come together with high support and high challenge around how we're delivering those services. So women broadly are feeding back positive in both services. However, the Southmead side, people are saying there's some things around access to key elements of the service, and communication is a key good thing, but also a negative thing. So just encouraging clinicians and the midwives to work together on levelling up the experience for women. We're doing a lot of listening to women through Maternity and Neonatal Voices partnership, but there is way more that we can do, and indeed they are challenging us. And the Black Maternity Matters work that we will do as a board, but Marie, you and I have done previously, will really challenge us about how we're listening to our Black and minority ethnic women in Bristol, who we know their experience and their outcomes is not as good as Wigan. So some more work to do.
Tim, I can see you wanting to come.
So if I could move on to some other aspects, I will. I'd like to thank the colleague to my left, who has kept me feeling uncomfortable at every board regarding two very important issues which are related in this report. One is around stroke, and the other is around necrophema, time to theatre. And I bring to her at her last meeting a mixed end of term report. Stroke performance is improving, and we said it would. We've been working on this for a long time, but it does show us that the ability to get stroke patients into a stroke unit, which is the single most important factor in improving their outcome, is slowly but surely improving. It is very brittle, and it's dependent on the occupancy and the density of the hospital and the Southmead Hospital site. So we can expect, given Glyn's challenges, that this will not be sustained in next month's report, but we are showing some signs of improvement. And again, on stroke, now that we've completed the work with our consultant rota, we are seeing a pretty sustained improvement in the ability to be seen within 14 hours by a consultant with a specialist interest in stroke. And there is still a little bit further to do around data accuracy and data capture. With regard to necrophema, I can't report significant improvement, and this is now demonstrating why we need to focus the clinical strategy work, perhaps pivoting it away from elective orthopaedics, where we have seen very strong improvement, onto our trauma service, which we know is facilitated on 3 of our hospital sites, and 2 of which have significant challenges in juggling their emergency case load to allow timely access to theatre for patients with a fractured necrophema. So more work to do there, I'm afraid.
I'd like to respond. Look, I was so pleased to see the stroke performance. I thought it was absolutely brilliant. And I think in terms of the necrophemia, I think this just shows why the merger was the right thing to do. Because if you are in Southmead, you've got 82% of patients will receive surgery within 36 hours. Whereas if you're on the BRI or the Western site, 23 patients didn't get their surgery, and 5 patients at Western. Clearly, you cannot say that that is a fair or equitable access to services. So I really thank you for taking on board, and I'm going to be passing my baton over to other non-exec directors who will be asking you and keeping on top of it, because the people of BRI and Western deserve to have similar access to services as if they were going to Southmead. But I really thank you, because you've treated it with utmost respect, and I really value the effort that you're putting in. But I think this just is testament to why merger and making services right for people, regardless of where they live, is absolutely the right thing to do. So thank you.
Great. Is that a appropriate moment then to move on to the next section of the report? So Jenny?
Yeah, I'm really mindful of time, so I will just focus in on 2 areas, vacancies and sickness. primarily just because they are such a core metric in terms of our overall productivity and quality of care. The vacancies are coming down over what has been a difficult period over the past 6 to 8 months, and you can see the impact description in the forecast that we want to see that to continue to improve. I am just going to circle back round the fact that we planned as 2 separate organisations, and therefore the Bristol and Western site have got a different target that I just want to circle back round the assumptions for the target. And then sickness, we have got and agreed the same target and putting a lot of effort into reducing sickness absence. Historically, a lot of that effort has been around the management of when people are off sick. What I'm really excited about, and we'll bring the early work through to People Committee in the next couple of weeks, our breakthrough objective using Patient First is very much focused on the underlying determinants of absence, and those are the things that we are trying now to take more of a preventative and upstream approach to, but also using the Patient First discipline that really helps us to focus in the areas that will make a difference. So really keen to see the sickness absence reduction over the coming months. So I'll leave it there.
Okay, thank you, Jenny. Any points to pick up on the people section of the report? Okay, in which case we'll move on to finance, please, Neil.
Thank you. As is often the case, month 2 figures are in the report, but I can bring that up to date in terms of the figures to the end of June, month 3. Okay, sorry. I'm going to focus on month 3 rather than the month 2 figures included in the report. And I will refer to the form for trusts for the last time in doing so. UHBW at month 3 had a deficit of 10.5 million. That is in line with the plan for the year to date. Colleagues will recall that we do have a profile in terms of deficit in the first part of the year, recovery in the second part of the year. Capital spend of £23 million for the year to date, which is on plan, and cash remains healthy at £67 million. 2 main drivers of financial challenge in the first part of the year: a shortfall in terms of elective income, a particularly weak month in June. This would of course reflect the operational context that in this case Stu has described. CIP delivery of 10 million against an 11.8 million pounds target for the year to date. MBT also on plan at a 3.7 million pounds deficit at the end of the first quarter. This of course is particularly significant in that will be the closing position for the North Bristol Trust. Similar issues: shortfall on elective income of £500 million, shortfall on CIP delivery of around £2 million, capital spend of £6 million for the year to date. Cash is lower than planned for the year to date. That was part of the exercise that we undertook in closing the books for MBT to make sure that we had a bit of a clearing of the decks in terms of creditor payments. The 3 activities I'd highlight in terms of priorities for the second quarter: firstly, that we will move on to the single ledger in month 4 and a single external report. That work preparation is progressing well. Secondly, NHSE will undertake a review of the conditions that were highlighted when our plan was approved. So that's really around progress in terms of unidentified and higher risk savings. So we're again well prepared for that review. And thirdly, the extent to which we will use the productivity pack information to drive improvements both in terms of performance and elective income, and that will be a significant feature of our respective finance sustainability boards and then reported into our finance and estates committee. And I'll stop there.
Thanks very much, Neil, for the update.
So you describe a fall in elective income, but that would be due to a fall in activity.
Yes, so it's more prevalent in Bristol and Western.
Yeah, I suppose I meant when we're not doing the activity, how do we offset that lack of income by reducing rosters and staff mix if we're not doing the activity? How does that marry up? I know it's not an exact science, and sometimes we're responding and reacting, be it theatre closure due to heat, etc. I just wondered, is there enough focus on recouping those costs when we don't do the activity?
Yeah, and some of the loss of activity will be very much at the 12th hour in terms of ability to react. I'd also say that the 1.8 million shortfall for the year to date, in the context of the level of activity we undertake, is pretty marginal. Also, just to highlight that in the year-to-date position, we also have circa £2 million worth of costs associated with the industrial action that we've had to cover ourselves in the absence of any central resource. So that would have also, at a marginal level, played into that underperformance. So I don't feel that there's a lost opportunity in terms of should we be shutting off some of those costs, given the dependency on a non-elective activity that's earlier been described.
Okay. Not seeing any other hands. So I think we may have reached the end of our discussion on the report, which is for note and assurance. So thank you all for that. And we will move on somewhat belatedly to the Patient Safety Incident Response Plan. Steve.
Yes, thank you, Chair. And just to say that Quality and Outcomes Committee have already reviewed this paper alongside both of the clinical quality review groups of both former organisations. We really do have to be bilingual. So just to highlight, this is the plan for 26 to 28, so our 2-year plan around patient safety improvement. I'm really delighted to say that both former organisations, patient safety teams, came together to work on this plan. They pulled a whole variety of different sources and information to be able to come up with the key areas of focus for us organisationally. There was a list, an original list of a long list of 8 themes, which have now been prioritised into 4. The 5th, however, will be around maternity services. So the 4 are detailed there. So Mental Capacity Act, medicine safety, VTE, and the overall experience around discharge and transfer of care delays. These are areas of safety focus for us. They also link with our quality priorities that we set this year, and we'll need to do a little bit of an assessment around the new quality strategy that has come out 20 minutes ago to make sure that we're aligned, but I can't imagine that we wouldn't be. So colleagues, this is here for approval. So it's already been through Quality and Outcomes Committee and had a good test there. Very happy to take questions.
Thank you very much, Steve. Mark.
Super quick. Steve, I thought it was a really good report. There's a reference to risk and opportunities in the covering paper about human factors. It's been a little while since we've had anything about human factors kind of brought to board. I'd just be keen, maybe not for now, but just to see make sure that we are making those connections and making the most from them, because I believe they will offer us massive benefits and to our patients as well. So it's just a note there. And it's good to have it captured, actually, Steve, as well.
Yeah. And just on that, if I may, Chair, so in terms of human factors, we, UHBW at the time was sort of really leading the way in terms of engaging in human factors, and the specialists we have are superb in terms of Laura. We have agreed to invest further into human factors team as part of the new structure that we're currently doing. It's proposals at the minute, but we are investing a little more in that. So I'm delighted that we're doing that. But also working with Jenny and her team around the fatigue management work that we got the additional funding for from the charity. That's beginning to show some real opportunity.
and please can I plead that you publish this work and you get it out there, because this is
Laura will
really
do
good
that
work.
without doubt, but yeah.
Okay, thank you. And just by the way, the regional chair has started convening regional chairs meetings now, and one of those very recently was on quality, and it was exactly highlighting this. Is it Stephen Rowe? Ben Rowe, thank you.
Yeah.
Is going to be initiating a regional piece following on from the national quality, but it will be focusing quite heavily on human factors as an approach.
Good connections
So,
with Ben's.
yeah.
And well, John used that.
So that sounds like we're all on the same page on that one. I'm going to Jenny and then Poku.
I just wanted to come in on the fatigue work, because I suspect most of you are thinking, what on earth is that? Sorry. So I just wanted to come in on the fatigue work, because I suspect most of you are thinking, I don't really know what that is. And I'm meeting, so we've several engagement sessions set up. The first one is with the Trust executive team in the next couple of weeks, just to be able to help all of the execs, rather than just Steve and I, understand exactly what that work is trying to achieve, and also what the 6 pilots are already finding. This is an exciting piece of work. It's looking at fatigue and the way the NHS, the risks associated with fatigue, and how some of our systems and processes actually might go as far as designing fatigue into the way we work, rather than designing fatigue out of the way that we work. So it's very much a sort of a systems approach with human factors elements sort of woven into it. I'm also just trying to educate the rest of my team, because it's very much a sort of a whole system approach rather than something that sits with people. Having done both of those things, will give some thought as to how we then best bring that work here, so that as a board you understand it. There's quite high expectations nationally. So back to your point about publishing the work, the NHS Charities Together have funded it. NHSE are really keen to see how we are progressing with the pilots. Laura Pickett will always say, as the expert in this space, we are not going to shift this in a 12-month pilot scenario. So we are needing to think about how already we move from pilot to BAU. But I will just make sure that there's quite a high expectation around this piece of work outside of the organisation, and we'll ensure the board sort of better understands it now that we've kicked the pilots off.
Great, that would be very welcome. Thank you. Poku.
Hello, Steve. Yeah, I also thought the plan was insightful. Still learning, but it will feel like I'm circling a bit back to patient experience. I did do a visit to the headquarters with the patient's team, and they talked a fair bit about the challenges as it comes through the data from both patients and family and friends, and pointing out about discharge experience and division managers probably not acting as quickly on feedback. I did ask him a question as to whether they further analyze this data through the lens of the demographic data, and it didn't seem so. So taking that into consideration, I wanted to find out from you whether you have oversight of that, particularly given that it will have some relations or some impact on health equities. Or are they plans in relation to ensuring that?
Yeah, thank you.
The pilot data gets analysed.
Yeah, thank you, Poppius. So increasingly, all of our data needs to have the health equity lens on it, particularly in terms of ethnicity and deprivation and gender. Increasingly, we're great to see that coming through board, because I think they're the health inequality questions we should be asking ourselves. Some of the mechanisms by which we collect the data at the moment don't provide the opportunity to either clock a postcode or an ethnicity profile. So we are working with a broad range of teams in our digital teams to ensure that the way that we collect data can pull that information. There is some work going on across both organisations around ethnicity recording, and that is slowly improving. And in fact, Tim, the lens that we've used through cardiology group clinical strategy, some of that was around ethnicity. and we could see the DNA rate and other aspects of cardiology outpatients work, there was a differential between white patients and those from the black and minority ethnic community. So increasingly we are using the data to target our intervention, but also our understanding about how all of our patients experience our services. But there's still some way to go. We've got a health equity plan that comes through Quality and Outcomes Committee. That will be progressed as we go through this year to what I hope will become a health inequalities strategy that Tim and I will sponsor, because we now have public health consultant. We'll have a new health equity and inclusion team once we've gone through the consultation for staff. So I think my ask would be is keep challenging me and us on that, but also the data that we start to see coming through should have a number of lenses on going forward that gives us better insight into how all of our communities are experiencing our care. Thanks for the question.
And fair challenge about needing to see board papers. We've been talking about this bit, haven't we, Lavinia? About having that health inequalities lens running like Brighton Rock, actually, through everything that we're seeing around this table. So work in progress, as you say, but absolutely the right direction of travel. I saw a hand, but I've lost it. Roy, thank you.
Thank you, Ingrid. A very quick one. Steve, thank you. It's a great report. Really like how the themes are set out. One observation, really, which is around the survey from the staff. We had 195 respondents across groups. It's great, but given the size of our trust, it's not amazing. And really the observation is perhaps there are things we don't know yet around patient safety, and just to have one.
Yeah, I agree. I agree. Thank you. I think the important thing, and if you look at the sources of data, the multiple sources of data that the teams have used to come up with the long list and then the short list are pretty extensive. The lens we have into staff is actually the staff survey, where we had significantly more people responding. So I'm not surprised there were a smaller number, because this was a specific questionnaire. But I think I'd point us to the staff survey around some of the safety questions that are in there. But you're right. An organisation, a high reliability organisation, HROs, have an inherent fascination with things when they go wrong, and so therefore we don't know everything that's gone wrong if people don't tell us. So we use DATIX incident reporting. There's other examples of where we have near misses and where things have gone wrong. So there's a multitude of data. I think what I'm saying is, in a long-winded way, is it's perhaps disappointing we only had 195, but there are a whole multitude of other sources where people are giving us their feedback and their in-time experience about when things go wrong or when we have a near miss. So I'm reassured by all the other mechanisms that we have.
Okay, great. Thank you very much. I think we have exhausted the hands. So we are being asked to approve this, noting the 4 priorities that Steve has highlighted of Mental Capacity Act, medicine safety, BTE, and discharge and transfer of care delays, plus you added maternity.
Well, I shouldn't add things at the last minute, but I think
But
the
yeah,
work we're going
given
to do
everything
around
that's,
maternity, it is one of our key safety priorities for this year. It's not on the piece serve, but it is a promise.
Yeah.
Just to
So
acknowledge
we will note that as well. So are we happy to approve the report? Okay, great. Thank you. Right, next item is a really important one about the values programme. Jenny, do you want to introduce this for the work we're going to be doing for the soul of the new trust, I would say?
Yeah.
Okay.
Exactly that, Ingrid, exactly that. So I think Elliot and I are really keen to understand any builds that you might have on the paper, because we are literally at the design stage. As outlined in the paper, we took a conscious decision as a group of execs, and then that decision we took through People Committee, which was to do the values creation work post-merger. Primarily the rationale for that was just the amount of work that was going into a merger that everybody recognised was being done at pace, and also the other 2 parallel transformation programmes where we were bringing, and still are bringing, our duplicated clinical services together and all of our corporate services together. So it was a conscious decision to do values creation post-merger. Several of you have sort of recognised the comms effort that went into the merger and how we heard back from staff that they understood it and that they saw it as a positive thing. I was pleasantly surprised in one of my town halls just before merger to hear staff had already moved past day one and were very much into year one. And one of the questions that was at the forefront of staff's mind was, and now how are we going to do values creation on behalf of the whole new organisation? The People Committee will know that we have done a desktop exercise around culture, so values are not the only thing that create the culture in an organisation. We know there are layers, and we've done a piece of work which, again, establishes quite a lot of synergy and continue to do the work, particularly around the different narrative between the two organisations and their journeys and histories to this point. We think we can augment that work with this values creation proposal that Trust Executive have supported. The board obviously plays a really important part in this process and in this activity. Typically, the NHS has always done values creation as an internally focused exercise. This is certainly the first one that I would do where we're wanting to draw external stakeholders into the exercise as well. The other piece I think that is quite different is we need to be able to help us take our stuff on, understand what left shift might mean for an organisation that is primarily hospital-based, ahead of Tim's clinical strategy in 2027. And that was a really sort of key decision point to be taken. Do we do the values creation before or after? Because of the interest, we've chosen to do it before. So we've got a little bit of work to do, which says, how do we do values creation that doesn't just describe the organisation as it is at the minute, but also one that is forward-looking and need to be able to help staff understand what that forward-looking picture is, as well as we see the opportunity to be able to really celebrate both organisations' successes and journeys to date. So it's a very important and quite sort of, we've tried to make it quite a rounded activity. I've got to say thank you to Elliot. You were working on this at midnight when you were also trying to make sure day one and day two merger was going to be over the line. So we took the decision that we knew this would put pressure into the team and the system. But if we don't do this prior to December, this is going to be a 2027 activity. And that feels as if that slippage is unhelpful in terms of just really being able to augment and bring together the benefits of all of the work that have gone over the last year to get us to merger. So your builds on this, really, your comments on this, we're keen to hear those. This isn't set in stone. This is where we've got to, but we are in the process of really working this up. So, Elliot, anything you'd want to add?
So, I guess also just be to re-emphasise in how
it is just to re-emphasise how important that inclusive and capturing to minority voices is to this process. So built within it are several safeguards and ultimate checkpoints where we could actually tweak what we're doing as we go through the process. There is a natural process for doing that. The other is just to draw attention to the KPIs in particular. So we've tried to be quite granular there. They are distinct between reach, engage and involve. That's comms and engagement jargon, but really the difference there is making someone aware, having a conversation with them and then us translating it, and then involvement is physically focus group work, getting into the detail. We haven't promised full co-production. There is a reason for that, which is we're not starting from a blank sheet of paper. There are guidelines we have to follow, Constitution, CPC, etc. So we can't promise that, but involvement still creates something quite like it if you do it in the right way, and they're very much determined to do it in the right way. Also, that Jenny's laid down the challenge that we have some fun with this. So you'll hopefully see some new, interesting ways of engaging. One suggestion that's come up is actually cooking. But you'll see some of these come through to capture different cultures and how they might think about it in different ways, and having a discussion around a kitchen table as a focus group concept. So one idea. There are many. I'd love some more from all of you here. The only final one in timeline, which is we do have about a week or two's grace to hit our targets, but that is really it. So please be as brutal as you like here and now. It really would help.
Okay, thank you very much, Elliot and Jenny. Right, exciting stuff. Steve, do you want to kick this off?
Thank you. And Jenny and Elliot, thank you. Clearly very supportive. I guess my ask is around the community participation group and the wider opportunity for our communities to be involved in shaping the soul of our organisation, which I think is a beautiful way of describing it. And just the offer, I guess, of support for the CPG to ensure that they are actively involved. I know that they would like to be involved. But also the wider piece around how do we really engage with those communities who would struggle to not engage with us. And dinner or the kitchen table is a great example, but CPG will help give us the lens into some of those communities that wouldn't normally engage with us. So I think just to offer my support to the approach, but just to, I guess, really assure ourselves that we are generally getting engagement with our communities as we go forward. So great. Thank you, Jen.
Thank you, Steve. And Paula?
Yeah, it was really just a comment on, so I'm supporting working with Tim on the clinical strategy and thinking about the timeline. And actually, I think the timeline for really kicking off the clinical strategy work towards the autumn, coming into the autumn, will be really helpful to have some of those conversations in parallel, and use that same thought process to provoke a different way of thinking about the organisation we want to be, while ensuring we provide the services to the that we do as an acute provider to the quality that we need. So I think the timeline works really well. Jenny, actually, now that we're both beginning to firm those timelines up, with further work to flow then when the values work is concluded. So and I know we're having a conversation at private board about clinical strategy, so can pick up anything specific on timeline then.
Yeah, I mean, just to follow up, I'm really pleased to see the balance between where we are now and where we need to be. So it's vital, to blend the two things together in a hard way. So there's not sort of static thing that says, driving trust forward, which is really good to see. So great because we're working supporting.
And a quick one to say that I think it was great to see it, and not just values, but values and behaviours, which makes it more action oriented. It's just a note to what Elliot was saying. I was talking to this guy, long story short, and he talked about, yes, they're doing values work, but one of the metric that they'll be gauging through that values work and afterwards is enjoyment. And I thought, that's quite interesting. So I guess the methodology in itself, how we go about, if we can't do co-creation, the methodology in itself will be telling, I guess, as to how well people get on board. So I just wanted to note it.
Yeah. Poku, that might be why I was sort of quite keen for this to create energy and fun and the optimism and excitement. And, so, the method by which we do this is going to be really, really important, which the team are working on at the minute. Yeah. So any ideas that you've got, and Elliot, yeah?
I've just more, any, even if they sound totally impossible to implement, I'd still rather hear it and then work back from that. I mean, so genuinely looking at it. But the latest and greatest way of doing this, it creates that energy. So more merry.
Marie, I'm very supportive, and love the idea of this. Bringing energy and fun. But just a plea: if we're going to be having workshops, focus groups, networks, town halls, etc., that we build in that time into our schedules. That we absolutely have those people who are going to be involved scheduling well in advance, so that people can give their time. Otherwise we'll be back into the fatigue syndrome, I imagine, because a lot of this will be obviously on top of things. So if we're going to have good representation, the sooner we can plan for this over the next few months, the better.
as you'd expect, just to say fully supportive, really like the visible, practical and positive approach, really like the engagement piece. And I think acknowledging what's gone before and carrying it forwards, but at the same time developing something new is really exciting. We've got one chance to really get this right. And I think the plan certainly seems to be putting us on the right path for that. So very supportive.
Right, thank you. So sounds like quite a lot of enthusiasm for this, so thank you. I mean, I would add my voice to that. I think this is a really welcome approach, and I think it is really important that we do this, yes, with our 28,000 colleagues, but also with the partners and communities without whom we cannot deliver our ambitions. So they need to get it and feel like they're bought into what we're about as well as we ourselves. So I suppose who was it that said, be the change that you want to make, something like that, isn't it? So there is something about the way in which we do this. People have commented on the methodology, the engagement being really important. The way that we do this says something about who we want to be. So I think that methodology and that sense of encouraging people to be alongside us as partners is a really important thing. So yeah, hugely excited by this. Thank you. We will look forward to seeing outcomes in December. Sounds a terrifyingly short time phrase that I'm sure it can be done.
It can.
Great. So we are being asked, I think, to note the report and affirm our support for it. So happy to do that, I think, given the conversation that we've had. And we will move on to the integrated governance report, which I think we can take quite quickly. So first of all, if we could ask committee chairs to just highlight anything in particular that board needs to note from their upward reports, beginning with audit from the June meeting, Richard. So this would have been the year-end one. And
yeah,
of
this
course
is all external audits and annual accounts,
Yeah.
so nothing really to add to that.
Yeah.
today.
And the outputs of that would have come to the board meeting specifically on that anyway. So I think we can note that one and move on to digital. Roy, anything specific to highlight for board?
Nothing specific. We did a lot of work towards merger day one. So that was a big focus, and that's not done, but at least one hurdle overcome, and we're looking forward to the other pieces after this.
Right, lovely, thank you. Finance and Estates Committee, Martin, 26th of May. Anything to
No, I think Neil's updated us on the finance. I think the only thing I would say going forwards is we've got quite a complicated landscape in terms of savings plans now, because we've got CIPs, we've also got cluster savings programs, and we've also now got merger savings programs, which all need to come together in one overall plan, which is needs careful monitoring going forward. So.
Right. Okay, thank you. People Committee.
Yes, and similar vein, take the paper as read. Just a couple of things I think worth highlighting. The NHS England Transforming People Services programme is quite a big thing for us. 2 reasons. The South West has been identified as a real accelerator, and also we are very well positioned to take the lead in that and drive some real changes through. And so I think we'll be quite engaged in regional discussions and planning there. And then the second thing is the committee received an overview of the national immigration changes. I just want to flag that we're all noting really the importance of them, and B, the work that we're now undertaking to support them. Other than that, I think the paper summarises it all.
Okay, thank you. And Quality Committee, Sarah.
Thank you. You have
two committees, in fact. Yes.
So you have the 2 reports there. I think the only thing I wanted to highlight was that the group quality accounts were approved, final approval as delegated by the board, and they're now published. And I just wanted to...
Sarah, could you speak up?
I just wanted to note the amazing contribution of Sue and Sean as members of the committee and thank them for that.
Agreed. Here. Thank you. Okay, so are there any general comments about the committee reports? We do need to note the use of the seals. So nothing for MBT, but 2 uses for UHBW. Anything to highlight, Lavinia?
Nope.
Okay. In which case, is there any other business? No? Meeting closed. Thank you all very much.